and welcome back to the Journal of Oncology Practice podcast. This is Dr. Bob Miller, consultant editor for the Journal. You know, we've been doing these JOP podcasts since July 2010, and I've interviewed many healthcare professionals, including physicians, oncology nurses, practice administrators, and consultants. We've covered topics ranging from reimbursement for clinical services to the challenges of EHR implementation to the promises and pitfalls of using social media in oncology. But the one voice that has been missing is, in many ways, the single most important perspective, that of the patient. For this very special podcast, I am pleased to be able to speak to Stephanie Roberson Barnard, who wrote a perspective article for the JOP published online on January 21st entitled, "Is It Okay to Fire My Oncologist?" If you're an oncology healthcare professional listening to this, you really need to read this article. I'm sure it'll make you feel uncomfortable and then disappointed and then sad for the unfortunate experiences that she had to go through as part of her cancer care. But as uncomfortable as it might make us to hear this story, that cannot begin to compare to how uncomfortable and distressed it must have made her to have to suffer through this. I know I'm speaking for many who were moved by her story to say that we appreciate her honesty in sharing it, and I'm very grateful for her willingness to talk with me for this podcast. By way of introduction, Stephanie is a skills trainer and consultant for healthcare professionals. She's coached thousands of MDs, RNs, pharmacists, and others on public speaking, writing, and patient communication skills, and she's co-authored 2 books on these topics. But as she told me, I thought I was an expert patient until I actually became one. Stephanie, welcome, and thank you for joining me.
Thanks. I'm honored to be here.
So let me start with the obvious question. Why did you write this essay?
I wrote it for 2 reasons: to express my own feelings and to speak for others going through similar experiences. I hope my essay puts a face with the story and helps the people who read it think about how important it is to communicate effectively in this setting.
How did you feel during your cancer treatment? How did you feel emotionally?
I felt extremely sad. Some days I took to the bed. Being treated for cancer was emotionally draining for me and my family. I felt hypersensitive to everything in my world during that time. I can't tell you how many times I got in the shower where no one could hear me over the spray of the water and bawled. I'm the 3rd person in my immediate family to be diagnosed with breast cancer. My dad died from complications due to breast cancer. I took care of my younger sister when she had breast cancer. When I was being treated, sometimes it was hard for me to appreciate how lucky I was that we found it early. I know this sounds dramatic, but nothing in life prepares you for facing your own mortality.
So as far as the healthcare team's response to your emotional needs, how did they do? Or at least what was your perception of their attention to that very important part of your care?
Some of the physicians addressed my emotional needs and some did not. The ones who did made the biggest difference in my recovery. They were my internist, my radiation oncologist, and my plastic surgeon. I'll start with my internist, who I also call the quarterback because she's excellent at calling the next play. I suffer from depression, so when my internist heard about my diagnosis, she summoned me. The day of my first care team consult, I called her office and left her a message to tell her about my diagnosis and to let her know I had resumed taking an antidepressant. Within hours, her receptionist called and said, "Dr. Lambert wants to see you tomorrow morning. What time can you come in?" That was exactly what I needed, someone to acknowledge and treat my emotional needs. The second person who addressed my emotional needs was my radiation oncologist. I didn't end up having radiation, but the radiation oncologist who was part of my care team was awesome. She's an excellent communicator, and her philosophy of making patients feel at ease is extended in the behavior of her staff. The third physician who monitored my emotional needs was my plastic surgeon. In the memoir I'm writing, I named him Dr. Black. This is an appropriate name for him because he's a bit of a dark knight. He's very quiet and methodical, yet one of the most empathetic people I've ever met. I remember standing in his treatment room, topless, full of stitches and drain tubes, complaining about not having my Oncotype DX test results back as promised. My eyes were full of tears, and I said, "I guess I'm just not very patient." He paused from milking my drain tubes, looked up at me, and quietly said, "I think you're very patient. You've been through a lot, and you've been very brave." That was a defining moment for me because I needed someone to validate how I felt. Dr. Black never criticized Dr. Clark. He just listened. He gave me a safe place to say exactly what I felt and to ask the most ridiculous questions without fear of being judged.
In the commentary that accompanies your article, which was written by Dr. Bruce Gold, who is an oncologist from Georgia, he asked the question, what took you so long to fire Dr. Clark? What would you say is the reason?
What took me so long to fire Dr. Clark? What a great question. I've asked myself this question many times, and the best answer I can find is I was beaten down by cancer. I kept thinking things would get better in that practice if I just pushed through. What made me finally fire him? I have several reasons. Since JOP released my essay, I've received email messages from physicians, nurses, and patients from all over the world howling about the injection in the bathroom. It's probably the most shocking thing that happened to me in that practice. When I look back, however, the thing that bothered me even more that day was an interaction with Nurse Amy. My BP was high. She asked me what was going on in my life, and I told her I was stressed. Then she said, "Well, if everyday life is causing you this much anxiety, that's bad."
Stephanie, in your article, you describe how you called Dr. Clark on the phone after canceling your appointments. Tell me a little bit about that phone call.
I felt obligated to share my reasons for leaving so he could improve his practice for other patients, and I was impressed that he asked to speak with me. He was very gracious and thanked me for telling him why.
Now, you witnessed many things in that office that were substandard by anyone's definition. If it were up to you, what would you recommend that Dr. Clark do to improve his practice?
I wrote about this in my essay as well, but here's a quick review of the 4 things I told Dr. Clark on the phone that day. Number 1, set up a system to monitor labs and get those results to patients swiftly. Number 2, train your staff to be friendly, competent, and an extension of your philosophy. Number 3, protect your patient's privacy. And number 4, establish a protocol for routine procedures, such as counseling patients, and make sure your staff understands what they're explaining.
So it sounds like the root of a lot of this was communication, and I think it's a well-known reason that one of the main reasons for patient dissatisfaction with their doctors is poor communication. Those examples you just gave are very good jumping off place, I think. But do you have any other advice for oncologists to improve the way that they can communicate with their patients?
I could talk about this all day, but since we only have a few minutes, I'll give you my top 4.
Sure.
Number 1, listen to your patients and their caregivers. And I don't mean nod, smile, and act like you care. I mean really listen. Pay attention and process what they're saying. Think about your answers before you start talking. Number 2, be accountable to your patients. The thing that annoyed me the most when I was being treated for cancer and a staph infection was when different providers pointed the finger at each other instead of accepting responsibility. Telling a cancer patient whose appointment is specifically for tumor test results that someone forgot to send the tumor is lame. Number 3, show empathy toward your patients. One of the most effective ways to do this is to validate what your patients are saying. In other words, don't blow us off. I know it must be hard to empathize with every patient who comes in the door. This is where your support staff can really help you. If they do an effective job of listening and validating each patient's concerns, they'll make you look better and they'll help your patients. Number 4, respect your patients, their opinions, and their time. This one is so important, I'm going to break it down further. Respect your patients. We're smart. Many of us are well informed. The PA in Dr. Clark's office was very friendly and kind, but she wasn't prepared to counsel me on the Ghostler injection. In fact, it was obvious she hadn't read my chart or learned about the drug prior to meeting with my husband and me. She read aloud from a website the same information I had read the night before. We immediately lost respect for her because she was not prepared to answer our questions and wasted our time. Respect your patient's opinions. If a patient is bold enough to ask a question, know that it must be important and find the answer. And finally, respect your patient's time. I'm not just talking about running on schedule. I'm talking about making your patients wait excessive amounts of time to hear lab results. This is a problem I've observed more than once in the community healthcare setting. It's an insult to be told you have to wait through the weekend for test results that can be determined in a matter of minutes.
I'm going to play devil's advocate for a minute and suggest that maybe some of the things you went through were somewhat excusable, or at least explainable. I don't think anyone's going to try to justify giving a shot in a bathroom, but is it plausible that some of the other things might have a rational explanation? For example, in many medical oncology practices, the Oncotype test is not ordered until the first consultation with the medical oncologist, so that he or she can discuss the pros and cons with the patient face to face. So that means that there's kind of a built-in delay of 2 to 3 weeks minimum. That's what we do at my institution. And the other question I would have, in just reading through your essay, is the example that you give about the nurse not knowing the charge. I think you alluded to this a moment ago. While that's true, it may not be until the charge is submitted, given the vagaries of various insurances, that the individual practice may be aware of exactly what the patient's responsibility. Let me ask it this way: if the same things had happened to you that you described in your article, but there was some attempt at explaining this on the part of the staff, do you think that would have changed anything?
Before I answer that question, let me clarify that this was not my first visit with Dr. Clark.
Okay.
In fact, this appointment was made specifically to go over my Oncotype test results.
I see.
As for the nurse not knowing the cost of the injection, why not? I did a quick Google search and found out it typically costs about $2,600. If she's offering to help people get financial aid for this shot, shouldn't she have some idea of the cost? Something I didn't mention in my essay: Nurse Amy promised to find out the charge and call me back within a few days, and she didn't ever do that. And to answer your question, I don't think explanations can take the place of actions. In both of these examples, people promised me information and didn't follow through, not even to tell me they couldn't get it.
I thought one of your comments in the last few paragraphs was particularly telling when you say about Dr. Clark, quote, "He's a quiet man, and this lesson has sucked out any viable excuses. It's clear that his employees supervise him, and my dissatisfaction is a surprise." And that's the end of the quote. What advice would you give him?
This is your practice, and when your staff is rude, incompetent, or ineffective, it reflects poorly on you. It doesn't matter where you trained, how many papers you've published, or even how many lives you've saved. Patients come to you to feel better. They should leave your office feeling hopeful.
Do you think empathy can really be taught?
Yes, I have physicians in my family, and I understand the wealth of things that a person must master to become a good doctor. I think medical, pharmacy, and nursing schools should incorporate communication skills training at every level, so that when these students finally finish their training, showing empathy is second nature to them. A great example for your listeners is a YouTube video where Dr. Abraham Verghese from California shows the examination of the hand for Google Glass. It's a brilliant example of how to communicate effectively with a patient during an exam. Dr. Verghese demonstrates that it doesn't take more time to show empathy.
Now, you're a consultant who teaches communication skills. What do you think the most effective strategy would be for educating busy oncologists and their office staff in skills that can improve the ability to recognize and satisfy patient needs?
Ongoing training. If you look at any successful business model, the secret is continual improvement. You can do this by devoting 10 minutes to each weekly staff meeting for education. Ask staff members to take turns presenting relevant communication skills topics, such as how to deal with an upset patient. Tell them not to complicate it with slides and lots of details. Instead, ask them to give specific examples and solutions that apply to your practice.
Stephanie, are there any other lessons that you would want to share with our listeners about your experience?
I do have one more story for you. Before I share it, I want to emphasize two important things. First, I'm well. My cancer is long gone. I've shifted back into the routine of everyday life, and it's nice. Second, I'm doing so well because many healthcare professionals took great care of me and my family. For that, I'm very grateful. Now for the story. You know, I've been a communication skills trainer for healthcare professionals for over 17 years. A few years ago, I was invited to present at the Centers for Disease Control in Atlanta. As I was riding on the airport shuttle to my hotel, I ended up chatting with a physician and his wife. The wife asked me why I was visiting Atlanta. When I told her I was giving a presentation at the CDC, the physician perked up and said, "Are you a doctor?" I said, "No, but I train doctors on communication skills." He said, "If I were the patient, I'd rather have a good cutter." And I said, "Isn't it possible to be both a good physician and a good communicator? Must they be mutually exclusive?"
Stephanie, thank you very much for writing your story for JOP and for sharing your experiences with me today.
Thanks to you and the editors of JOP for highlighting this important topic.
And thanks again to Stephanie Roberson Barnard for being my guest on the JOP podcast. As always, your comments about our podcast are most welcome at jopeditorsdesk@asco.org, or you can comment directly on our iTunes page. Come back soon for our next interview in a few weeks with Dr. Russ Hoverman on the topic of ASCO's Choosing Wisely campaign. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for your attention.